Welcome everyone to our presentation on multiple sclerosis for the class Prevention and Rehabilitation of Complex Chronic Conditions. In this presentation, we will take a look at what a chronic disease is and why MS is considered chronic, the descriptive epidemiology of the disease, characteristics and symptoms, and what makes MS a complex disease. We will also look at a rehabilitation strategy for multiple sclerosis and examine a research publication regarding the program. According to the Ministry of Health and Long-Term Care, a chronic disease is one that has a slow progression but has a long duration. These diseases are usually treated and can be controlled, but are rarely cured. They can have severe impacts on the quality of life as well as many aspects of daily living. Examples of chronic conditions are cancer, diabetes, and multiple sclerosis. Multiple sclerosis is a serious disease that affects the central nervous system, causing a gradual degradation of the nervous system. This leads to numerous signs and symptoms depending on which area of the nervous system is affected. Multiple sclerosis is a long-term disease lasting the entire lifetime after it is diagnosed. In addition, it is a slowly progressing disease requiring long-term treatment plans, usually consisting of multiple treatments to help reduce the severity of the symptoms. All of these characteristics point towards multiple sclerosis being a chronic disease.
Multiple sclerosis is the most common disabling neurological condition in young adults worldwide. It affects up to 3 times as many women as men, with a typical age of onset between ages 20 and 50 years. The finding from the World Health Organization MS survey estimates the number of people with MS had increased from 2.1 million in 2008 to 2.3 million people in 2013. There are also 400,000 cases in the United States, with about 200 new cases diagnosed each week. The MS Atlas ranked Canada the highest in incidence of multiple sclerosis with 291 cases per 100,000 people, followed by Denmark and Sweden. Previous application in 2008 ranked Canada the fifth at 132.5 per 100,000 people. According to this atlas, incidence of multiple sclerosis in Canada has more than doubled in just 5 years. 1 in every 2 Canadians knows someone with MS. According to the Multiple Sclerosis Society of Canada, nearly 100,000 Canadians have the disease, a rate 28% higher than the country with the second highest, which is Denmark. MS incidence is considered high if a country has more than 30 cases per 100,000 people. The total lifetime cost is $1.6 million for each person with MS. The Public Health Agency of Canada also estimated the total cost of MS in 2000 to 2001 at $1 billion. The Multiple Sclerosis Society believe the cost of care has doubled since then. The incidence among the provinces also varies, from a high of 350 cases for every 100,000 people in the Atlantic to a lowest of 180 cases per 100,000 people in Quebec. Ontario has incidence of 230 per 100,000 people. Those who live closest to the equator have the lowest incidence of MS. The disease is nearly absent among Canada's Inuit people in the high Arctic and among indigenous people in North America, and is rarely found in Japan.
Common characteristics of MS can be seen as depression, degenerative muscles, fatigue, and lesions on the central nervous system. Those who have MS have a higher chance of developing depression due to the decrease in quality of life because of a rapid decrease in health. These lesions are found in the white matter of the central nervous system. An individual must have the presence of 2 lesions that have appeared at 2 separate times for the patient to be diagnosed with multiple sclerosis. As one can see from the brain scans on the slide, the white orbs that are showing up are seen as the lesions. A patient can also develop lesions along the spinal cord. There's no specific test to diagnose MS as it presents itself differently among individuals, but there are some common symptoms such as fatigue, difficulty walking, numb feeling in the arms, legs, body, and face, as well as muscle weakness, vision problems, dizziness, bowel issues, and pain. One of the most common symptoms of MS is fatigue. 74% of patients with MS have experienced some sort of fatigue from mild to severe. There are also less common symptoms that can be seen as a symptom of MS. Those are issues with talking, difficulty swallowing, seizures, trouble breathing, and hearing loss.
A complex disease is defined as having at least one of the following themes: more than one disease, an increase in healthcare utilization, and psychosocial, environmental, and lifestyle factors. Multiple sclerosis is a complex disease because all of these themes are present among individuals with this disease. Patients who have been diagnosed with multiple sclerosis use an uneven amount of medical resources. Since this disease does not have a cure as of yet, there is an increased use of healthcare resources among these patients due to increased hospitalization, visits to physicians, and emergency department visits. These frequent healthcare visits are a result of prolonged treatments, such as symptom management and MS disease-modifying therapies. For example, a study conducted in the United States found that newly diagnosed MS patients have significantly higher rates of hospitalization, radiology services, and emergency room and outpatient visits compared to patients without this disease. It was also found that within the first year of diagnosis presents a considerable burden on the healthcare system. Everyone experiences multiple sclerosis differently because there are various types of this disease. This can be very costly to the healthcare system because research is needed in order to decipher the different types of multiple sclerosis efficiently and provide the proper medication for each type. Research is another factor which results in an increased healthcare utilization for multiple sclerosis because the disease is so complex and very costly on our healthcare system. There has also been extensive research to investigate potential triggers of MS and why some factors may increase susceptibility to this disease. Also, research is focused on the cellular mechanisms that result in either damage or repair of myelin and underlying nerve cells. As a result, multiple sclerosis is a complex disease due to its uneven use of healthcare resources and the burden it places on our services.
Oftentimes, patients with chronic conditions can develop secondary conditions or comorbidities associated with their initial diagnosis. In the case of multiple sclerosis, these comorbidities are often called consequential comorbidities, meaning that the index case or initial diagnosis the patient has plays a large factor in the development of secondary chronic conditions. Consequential comorbidities can be thought of as a type of cause and effect relationship, the cause being the initial diagnosis and its effect on the development of other chronic conditions. For instance, those with multiple sclerosis have been known to develop the secondary condition dysphagia or have trouble swallowing. Dysphagia will usually appear in patients with more advanced cases of multiple sclerosis. However, it can appear at any stage of the condition. Those who develop dysphagia usually will have trouble with a variety of different textures of foods and liquids, making it much more difficult for the patient to receive adequate nutrition. If the dysphagia becomes too severe, it is not uncommon that these patients will have to receive nutrition from a feeding tube. As well, many patients who experience dysphagia have been known to develop speech disorders. Usually, treatment for dysphagia includes different types of swallowing exercises, changing the patient's diet to more tolerable foods, or practicing safer eating strategies. However, a new treatment called expiratory muscle strength training, or EMST, may be beneficial to those experiencing dysphagia, especially if they have also developed speech disorders.
Expiratory muscle strength training, also known as EMST, is a new rehabilitation program used to treat chronic illnesses such as MS, Parkinson's disease, COPD, and voice disorders. In these diseases, respiratory function is usually affected, causing speech, swallow, voice, and cough inabilities. In order to swallow, muscle strength and coordination are critical. EMST incorporates principles of exercise and neuroplasticity with handheld devices categorized into either resistance or pressure threshold types for successful rehabilitation. As mentioned previously, dysphagia is secondary to neuromuscular impairments. EMST helps improve swallowing by increasing the muscle strength of the swallow muscles. The training also helps with coughing for patients with dysphagia. Those who have trouble swallowing experience trouble with coughing, which is how choking occurs. They are at high risk for penetration and aspiration. EMST focuses on improving maximal expiratory pressure associated with coughing, improving coordination and accuracy of the swallow function. The EMST 150, for example, is a popular and successful training device. A patient would exhale through the device as the pressure load is progressively turned by valve. The valve fails to release when the patient cannot exhale strong enough. This exercise is repeated through weekly sessions in order to improve a patient's threshold hold and respiratory muscle weakness. Swallowing safety then improves with less penetration or aspiration. This tool is often used in EMST.
The study we decided to look at examined the effectiveness of expiratory muscle strength training on individuals with multiple sclerosis. The study involved 17 individuals with multiple sclerosis and 13 healthy controls. The study examined outcomes by measuring maximal expiratory pressure, sustained vowel prolongation, words per minute, and quality of life indicators related to dysarthria, which means slurred speech, and dysphonia, which is difficulty speaking. Prior to training, individuals with multiple sclerosis had lower maximal expiratory pressure, shorter sustained vowel prolongation, and less words per minute than the controls. Following the training, both groups had significant improvement in maximal expiratory pressure that remained above baseline after training had stopped. The training did not improve voice production or voice-related quality of life for individuals with multiple sclerosis. Overall, the training improved expiratory muscle strength but did not statistically change voice and speech production in individuals with multiple sclerosis.
We will now critique the research article by Chiara, Martin, and Sapienza through the use of the 11 items of the Pedro scale, which was last amended on June 21, 1999. The first item of the Pedro scale is that eligibility criteria is specified. This is used to measure external validity. In this research article, this criterion is met through the inclusion and exclusion criteria that determine which participants were eligible for the study. For example, the inclusion of participants between 20 and 50 for the study. For example, the inclusion of participants between 20 and 59 years of age. The second criteria is that subjects were randomly allocated to groups. This criterion was not met in the study as participants were divided into two groups, the first being healthy participants. Criterion 3 of the Pedro scale states that allocation is concealed. This criterion also was not met because of the nature of the groups. Criterion 4 states that the groups were similar at baseline regarding the most important prognostic indicators. At baseline, MS patients were to have similar prognostic indicators. At baseline, MS patients were to have similar. Criterion 5 states that there were blinding of all subjects. Subjects in this research study were not blinded as they all received the same treatment, and therefore the criterion was not met. There was blinding of all therapists who administered the therapy in Criterion 6. All therapists who administered the therapy in Criterion 6. The therapists were aware of what group each participant belonged to. Criterion 7 states that there were blinding of all assessors who measured at least one key outcome, and this criterion was not met as assessors were aware of what group participants belonged to. In Criterion 8, measures of at least one key outcome were obtained from more than 80. Criterion 8, measures of at least one key outcome were obtained from more than 85% of the subjects initially allocated to groups. At the end of the study, only 80% of participants. Criterion 9 states that all subjects for whom outcome measures were available received the treatment or control condition as allocated, or where this was not the case, data for at least one key outcome was analyzed by intention to treat. This criterion was met as all subjects received the same treatment throughout the entire. This criterion was met as all subjects received the same treatment throughout the entire course of the study. Super-ANOVA and StatView is used as a one-way analysis of variance in the study by Chiara, Martin, and Sapienza, which meets the 10th criteria that the results of Sapienza, which meets the 10th criteria that the results of between-group statistical comparisons are reported for at least one key outcome. Finally, the inclusion of the calculated standard deviation between the control and participant groups show that the study provides both point measures and measures of variability for at least one key outcome, the 11th criterion of the Pedro scale.
We hope this presentation was very informative for you regarding multiple sclerosis. Thank you for listening.